Hello, everybody. This is Bob from a new thing now, the Meducate podcast. It's something we're going to be doing quite regularly, possibly once a week, and it's going to feature different aspects of the role of Meducate Academy and the role of the Associate Clinical Educators and the work they do. But without further ado, I've got guest speaker, course director, and I'd like to say a close friend, because I've known him a while now. James Ennis on the other end of this Zoom call. Good afternoon.
Hi there. Thanks
for having me. How are you doing, James? Yeah.
I'm good, thank you. How are you?
Yeah, good. So thanks, first of all, thanks for coming on and agreeing to do this.
My pleasure.
Because I just think it's, as a company, we can tell people how wonderful we are till the cows come home. And it doesn't mean anything. But Meducate have been working with you, and I've known you personally for a long time and worked with the University of Birmingham with you for about 8 years, 10 years, something like that.
Yep.
So I was hoping you'd sort of come on and sort of give us a bit, people listening, particularly different universities and institutions, give us some sort of insight into how you work and what value you find in working with associate clinical educators and role players, and how it can transform the training, I guess, of the PAs on the current course that you're running at Chester University.
Yeah, thanks, Bob. I mean, like you said, I've been working with associate clinical educators and role players for the best part of 10 years, I think.
Yeah.
And we've always had them within our curriculum, both at Birmingham and now at Chester. We've always thought it's a really important aspect to medical education. Actually invaluable. The feedback that we get from students is exceptional. I've never once had negative feedback from a student regarding associate clinical educators or role players, because they're such a valuable resource. And I say that in the nicest way possible, as a resource, because they're a non-threatening, welcoming layperson that has clinical knowledge, that is able to give constructive feedback to students in, like I say, this non-threatening environment, which sometimes they don't always feel that they get with academics or clinicians, because they're always trying to impress or to do something right.
Yeah. Sorry, James.
That level of feedback is important, isn't it, I think?
Yeah, what I've noticed, just to reiterate, sort of put more weight to the point you've made there, we are non-threatening. When I first started doing the work many years ago, I noticed that the students would actually sometimes sort of say, "Oh, thank God it's you," because the academics are a little bit scary, they have a different approach, I guess. And as you say, we're more approachable. We're in a sense, we're a bit like them. We're on the other side, as it were. But the good thing about it is actually we're not on anybody's side. We're there to help everybody. And obviously, we've been trained by people like yourself, clinicians who've had to train us to get to the level at which we are working, if you like. And that coupled with, obviously, I mean, I know a couple of times I've asked you about different sources. What's a good book to read, for example? And you've directed me to various websites and stuff. I mean, just the other day we were talking about the arthritis website, I believe it is.
That's right.
And that was really useful. Yeah. I mean, whilst I'm not a clinician myself, and I have to make that clear, I'm a lay educator, I'm still interested in the whole range of information available, because it helps me help the students. I mean, from the point of view of communication skills as well, obviously the role of the ACE is to come in and give feedback on the physical examination and whether somebody's auscultating in the correct place or percussing correctly, or palpating correctly. We also, a lot of time spent with communication. Can you chat a little bit about how you found that useful?
and I think there's multiple levels to that as well, not just, you know, talking to someone when you're taking a history or a medical history or consultation skills.
Yeah.
It's also with the skills needed to communicate within physical examinations. I think we're going away from this compartmentalization of history taking, physical exam procedure, because that's not the real world. You know, in the real world, the patient doesn't just come and we take a history or we just do a physical exam. It's often a multitude of things. You often dip in and out. And the great thing that ACEs provide, they've got that background knowledge with, you know, how to give feedback from physical examinations, but also from communication. And a part of a physical examination is history taking, is consulting with the patient, particularly with intimate examinations and things like that. Actually, that's often the hardest, you know, thing for the students to do, is to communicate at an appropriate level, professionally, to use of language, terminology, non-jargon, you know, those kinds of things that ACEs and role players are able to give, you know, exceptionally constructive feedback and develop the student far more holistically. So for me, like I say, it's an invaluable resource. And I don't know how you've found it over the years, Bob, but I think it's grown, you know, into something far more meaningful than we ever thought, perhaps.
Yeah.
That, you know, we've seen it from the other end as well. You know, the students and their feedback and their, you know, just the what they get from you guys is you can't really put a price on it, can you? It's pretty pretty worthwhile to see.
Well, I mean, you say it's worthwhile. I mean, from my point of view, working with it, because I started off as a role player about 12 years ago, and then got into the ACE work predominantly with working with Professor Pal, Jim Pal, who we both know from Birmingham University. And I wasn't sure how it was going to work out, but the working as an ACE worked beautifully when you'd done a lot of work as a role player. And I felt I was given a complete approach to a communication, if you like, because I knew more about what was going on clinically, if that makes sense. And what is really good about it was the fact that not only was I getting paid to do this great job, but actually students would genuinely come up to you and say, thanks very much. That what we did last week helped me in my OSCE station, you know. And that's worth a lot. And it's a win-win situation, really. Most of the ACEs that I've worked with, and there's some very, very good ones that you know, and I've worked with extensively, actually, it's not a job. And I was talking to Jim Parle about this. I said it's more of a vocation, almost. It's like, you know, doing this type of work, it's like, oh, I found my purpose. I mean, I don't want to sound too philosophical, but it's like, you know, I get real value from essentially speaking to students after I've worked with them, and them saying, oh, that's brilliant. You know, it makes me feel good. They feel good. And of course, the academics, they're like, oh, brilliant. These guys are going to get through their exams now. There are still lots of institutions not using ACEs.
Yes.
And I thought as well, coming back to your point about how I thought things were going, I thought by now, almost 10 years on now, that ACEs would be more widely used throughout the universities, particularly on the PA program. I mean, you know, I know the University of Birmingham have been using ACEs from an orthopedic point of view at the orthopedic hospital in Birmingham, the Royal Orthopedic, with fourth year medics, but it's never gone beyond that. And I always thought that was strange. Why? I mean, as an academic yourself and a clinician, why do you think there's, do you think there's resistance, or do you think people don't understand what we do?
I think it's a multitude of things. I think there's differences in terminology as well. So let's perhaps put that into context.
Yeah.
Many people aren't aware of this term, associate clinical educator. True. And they think of it as different things: simulated patient, role player, life model. There's lots of different terms. Male teaching associates, you know, gynae teaching associates. There's all of these terms. Yeah. And they can be kind of condensed as an umbrella term, as a simulated patient or something of that ilk. And they're used across other universities across the UK. but in different guises. I think you're right. There hasn't been that adoption of it as we would have thought, because of the feedback that we've personally received from students and you know, individual and institutional levels on how successful the role has been and implemented. I think part of it is lack of understanding and awareness. I think a part of it is costs and resources and investment. I think that's always a difficult thing to argue within academia, is that those upfront costs and investing in something that is longer term. So I think it's probably a multitude of those things. Obviously, with assessments now, I think more universities are adopting role players or adopting that model because of OSCEs or ISCEs or these other types of clinical examinations, because you just can't do it with a model, with a plastic model or etc. No. So I think from the assessment perspective or the assessment route, there is far more utilization, but that's again a distinctive difference there between assessment and teaching and learning. And you're obviously been a part of, you know, the full spectrum of it, so you've seen it from all areas, you know, from a teaching perspective, from a learning, from an assessment perspective, from OSCEs. So you've you know, seen it from different angles that students won't have, and you're able to feed that back in a constructive way. So yeah, I think it's used in different ways and for different purposes.
You're right about the terminology. There is a lot of confusion over what is an ACE, you know, what is a simulated patient, what is a role player, what is a life model. And you mentioned Mel Associates as well, which is something that it's been difficult to find people who are highly skilled at that particular thing. And yet it's probably, well, it's for the students especially, they'll say it's one of the most embarrassing things to have to do. Whereas when you've got an experienced ACE, and you know who I'm talking about here, he's probably one of the most experienced male teaching associates in the country, will make people so relaxed and comfortable, they're happy to talk about it and get on with the male physical examinations. And it's having, I think, being a good ACE is about personality as well, and having that balance. And you know who I'm talking about, of course. And he works alongside us when male teaching associates are needed, as well as role play and other clinical exams. But he has an ability to make the students smile and laugh while they're doing, you know, things, you know, like a DRE, for example, you know, and that's you're not going to get that off the average volunteer in the street, as it were. I think everybody's going to be nervous and everybody's going to be embarrassed.
Yeah, and that's another aspect to the role, isn't it? Is student anxieties, and there is some literature out there now, particularly around gynae teaching associates and intimate examinations.
And gynae as well, of course. Yeah.
Some students haven't ever examined a patient in that kind of setting, and it's very anxiety inducing. It's you know, it's a sensitive area that some people get kind of a little overwhelmed with, and again, that's something that we've seen across the piece, really, isn't it? Is that reduction in anxiety levels in order for the student to perform and to improve competencies.
Yeah, I mean, the level of confidence I've seen students when they've been working with my colleague on MTA work, male teaching associate stuff. They'll say that was just fantastic. It was, I mean, they genuinely, I'm not just saying this, you know, they'll go, I've just been working with your pal. It was brilliant. I was really worried, and I don't know what I was worried about, because it was so much fun, you know, and that's not making light of what he does. And that's what it should be. And I think the role of a good ACE is to make it fun, you know, so the students are smiling at the end of it, but they've gone away with a powerful message, and it helps them answer all of their questions they have about nerves, about OSCEs, about a physical examination itself. How does the patient feel? What should I say? How should I act when I'm going to perform a specific thing? And I've mentioned the term OSCE there, and I think people who are watching this will know what OSCEs are, part of the examination process in medicine. What I think one of our strengths as well, and obviously you guys utilize us at Chester, and when we work at Wolverhampton, and when I've worked with the ISU, obviously at Birmingham University, is our ability to, the fact we've done thousands of OSCEs. We've done more OSCEs than most of the academics. We've certainly done more OSCEs than the students we have in front of us. So we're able to help students deal with pre-OSCE nerves, anxieties, and actually how the examination should be performed within the allotted time to pass the exam. Have you seen that as a strength as well? I mean, when you've worked with us?
Absolutely. And sometimes you can give better feedback than I can with regard to approaches in that setting. Ultimately, my job is to ensure that they're clinically safe, clinically competent. And you guys can do that as well, but you give a different flavor, and like you say, from your breadth of experience with assessments, you can give that constructive feedback again, which perhaps I might lack, with counselling or whatever you might.
Because at the end of the day, you're trying to run a course. So you can't do all of this. And I know a lot of students get anxious, and obviously they'll always come to the academics or whoever's available to try and, explain why they're worried, and sometimes you just haven't got the time, essentially, in some cases, particularly when you have a really busy course, with maybe, I don't know, 5 or 6 cohorts of students. You can't deal with everybody. Whereas I think a good ACE, we'll spend a bit of time with the student, and I've done it myself, where we finished the training for the day, and one of the students has been hanging back, and I've said, "Are you okay?" And they go, "Can I have a word with you about the OSCEs that are coming up?" And again, that makes the job more worthwhile. It's more than just delivering the information and going, "Yeah, you palpated correctly, you auscultated in the incorrect position, move on." It's like they actually see you as somebody they can connect with. And when they hear that, that like we've had like 10 to 12 years of experience of doing OSCEs, as I say, both as a role player and as an ACE, it's really nice to get that. Now,
it's about building confidence as well, isn't it? It's that whole
absolutely, yeah. I mean, it's a stressful time for them, and I spend quite a lot of time, particularly just before nationals, actually online. I've had students, several of whom you've trained in the past, who've been worried, and they're good students. They're good students because they're concerned about passing. And they've contacted me on Twitter or Instagram or messaged me on Facebook and said, "Can I have a quick chat with you, Bob? I've got my exams coming up. Can I just run something past?" And whilst it takes up quite a bit of my time and it's not paid, I actually I get a lot out of it. Especially when that student comes on Twitter and said, "I passed my nationals, yeehaw." And you think, and I'm sure you get the same, from some of your students, you must get that same.
That's one of the beauties of working with you guys and the ACEs, is that enthusiasm. We're ultimately all trying to achieve the same thing, which is competent, safe clinicians, who have the confidence to get not just through their exams, but to be able to treat in a safe and professional manner. And that's something that, working with you guys, I've always had the impression that that's very much at the forefront of your teaching and your your agendas. So I mean, that's a joy to be a part of and to teach alongside with as well.
And it's fun.
You usually have a bit of a laugh as well.
Yeah, we have a laugh, and that's the thing, isn't it? And I think sometimes when students see the academic and the ACE actually having a bit of a laugh together, it allows them to relax a bit more, because they start to see you not as the course director. They sort of see you as, "Oh, James, he's just a normal guy, a regular guy who happens to be doing a job." It's, rather than being the big scary academic, which can be the case for some students. They've told me that. So my job is always to calm things down and make it a bit more fun. Yeah, just coming back to the jargon thing, because I went a bit off piste when we're talking about male teaching associates.
Yeah.
What I'll do in the description box below is I think I need to give some acronyms and explanations as to the terms that I use. Simulated patient, for example, life model, you know, and of course the ACE role as well. Do you ever see a day when the ACEs will be more widely used? Do you think, or is it just down to budgets? Do you think budget's always going to constrict? I mean, you know, at the end of the day, it should be about value, shouldn't it? When you're budgeting.
Yeah, it's that human factor, isn't it? So,
yeah.
you know, how should we educate our future clinicians who are going to be treating patients, human beings? We should use human beings, where and when possible and appropriate. I don't think there's any other feedback or any other way of achieving that. And like you say, there are other approaches. You know, some do peer-to-peer examinations, but ultimately, you know, those are trainees assessing trainees. They're unable to give that constructive feedback in a structured and meaningful way, as you guys would, obviously. So it's an interesting one. You know, obviously we're looking at that ourselves, and we're looking at how we can adopt that from a wider level. Mm-hmm. I think ultimately it's, you know, if we're going to be completely honest, I think a lot of it comes down to money and resources and availability, which is a real shame, because as we say, we think it, you know, really embellishes and enriches the students' experience.
Yeah.
And like we both, you know, alluded to, which is that ultimately they should be learning from examining people and real humans in a safe and professional fashion in simulation, and then moving up the learning trajectory into then, you know, unsupervised clinical practice, which is what we're building them up towards, and guiding them along, not just as clinicians, but as human beings themselves, you know, like you said, communication-wise, professionalism-wise, confidence, resilience, you know, all of these professional values, as well as learning to do the job properly and effectively as well. So, yes, I personally would love to see it adopted more widely, because I believe in it from a professional perspective, but also from a personal level, that it gives these, you know, it gives you guys, it gives the patient a voice, which we sometimes forget about. In the NHS, ultimately, what are we trying to do? We're trying to give the best possible care to humans, to people. They should always be at the forefront of our thoughts. And I think that's what I really recognize and value as importance here, is that you guys are giving the, you know, our patients a voice. And the students clearly appreciate that. They clearly see, they get that. That's, you know, that's tangible, that's real. Then that's, you know, you guys sometimes have pathologies that you're willing to share. You have your own journeys, your own experiences as not just as ACEs, but as people and as patients. You know, how often are we patients ourselves in the NHS?
Oh yeah.
And we're able to, you know, and you guys are able to give that in a meaningful way. And I think that as well is something that's forgotten. That's a shame, and we should value that and put our resources into that, I think. When we're training, you know, people to look after people.
Do you think the role of the associate clinical educator specifically, rather than simulated patient and role player, needs to be validated in some sort of way? Because there was talk, wasn't it, of having us validated, you know, by one of the organisations to say that we were qualified, safe to practice, and every year our techniques, if you like, would be examined, you know, because I, for one, was quite happy to be involved in that process, and I'd be more than happy to go through an examination process to demonstrate what I do know about MSK and GI and respiratory and cardiovascular, cranial nerves, neuro, and so on, you know, all the different systems.
Yeah. Absolutely, and we've spoken about this, and I think it's implicitly a requirement and an important need have some sort of accreditation process or some sort of monitoring,
Yeah.
because it is actually a robust system and people might not be aware of the robustness of it, and the training that goes into it and the preparation. Like you say, you know, you guys as individuals prepare, but you also prepare on a group level, on a, you know, on a team level as well, and a lot goes into that.
And there's a lot of I mean, you're right. I mean, if I'm doing, so for example, if I was asked to do cranial nerves tomorrow with students, then obviously I'd be, although I've done it thousands of times, I'll go through it again. You know, I use apps on my phone. I've got books on the shelves. If I'm not sure of something, I'll quickly flick through it, you know. So
exactly.
we do, quite a few of us take the job very, very seriously. I think that's why there's so few of us, to be honest. I think that's why there's so few of us practicing, because I think your regular role players are not keen to have to put that much work in, if you know what I mean, to help a student. They're happy to play the actor and give feedback on communication skills, because not a lot of investment in time. But if I'm doing, certainly when I was filming with you earlier on last week, me and my colleague Mark, we went through the knee, the hip, the shoulder, and the spine together, you know, in the car on the way up, just to make sure we knew what we were doing. And we take, you know, what I'm trying to say is we take the role seriously. And validation, you know, some form of accreditation would mean that if there were any aces who weren't up to speed, they would certainly either be retrained or moved on, you know, and left to do role play. And it always worries me when new aces come on board, you know, that there's no accreditation.
Yeah, I would completely second that, and it's something that needs looking at, not just on this level, but I mean, this could be transposed to many other things as well. But ultimately, you know, I think we need some sort of recognition, because especially if we are truly valuing it like we are, and we want it to continue and to grow, I think that is absolutely the next step. And some lobbying needs to be done on that behalf.
Yeah. You'll have to do that then.
Yeah, I'll do it in my spare time.
Oh, there's one other thing as well. COVID, the C-19 thing. How has that changed your working practices with the students? I know Chester were one of the few universities that I certainly know of that were up and running really quickly with the whole thing working online. How are you managing with that, and how have you been able to utilize our services, if you like, for some of the work we do?
Yeah, that's a good question, actually. So obviously in clinical practice, there's been significant changes, particularly in general practice and in the community where, like we're doing today. Talk to people online, or video conferencing, or video consultations, or telephone triage and telephone consultations have increased significantly across the UK. And what we're finding is that new ways of working, you know, with ever increasing technology, we obviously need to be aware of how we're developing, how we're communicating with people and patients. It will change. And the one thing that we've managed to do with you guys at Meducate is have you come in and develop the students' skills in preparation for them going out into a very different clinical environment. A lot of our students are still out in GP and out in clinical practice, consulting as we are today, talking online and talking to patients on the telephone or via a video conference. So you were able to give them feedback on how to do that well, you know, the structured approach to it. We've even kind of infiltrated from an academic perspective some of the literature, recent literature surrounding it, and you know, the good, the bad, and the ugly of kind of this way of communicating, really, isn't it? So I mean, it was something that again was fed back very positively from our cohorts. They loved it, and they found it really, even from an anxiety perspective, again, you know, they found it very welcoming and something that became a little less scary by doing it in simulation, by doing it with you guys in a safe environment before going out then and doing it in the real world in the clinical field with real patients.
Yeah, I mean it was a challenge for us as well, having suddenly going from working with students face to face to working online. And having been an actor, like most of the aces, we can embrace particularly visual technology such as cameras and microphones and so on quite quickly. But I realized very quickly that the students wouldn't get a handle on it. And actually, I had some feedback from a few students who sort of contacted me personally from Wolverhampton, asking about how do I use the technology? How come you seem to engage through the camera? And I've sort of said, well, you need to look at the simple things, like you need to look at the camera, not down here at the screen. Because if I'm looking down here at the screen, James, I'm not looking at you. But if I look at the camera, I'm looking at you. Now, it's human nature to want to look at the image down there because it's you down there.
Yeah.
So we've had to think about that as well, because obviously quite a lot of communication is body language, facial expression. So what I've had to do with my guys and me personally as well is learn to look at the camera and quickly look down at you when you're responding, and then act in that appropriate manner. And also things like just general lighting, make sure your computer set correctly, because obviously we know it's, people can't go out and afford to buy all this amazing kit. They're already paying for a course that they're working hard on and spending a lot of money on books and resources. Yeah. So they're not going to spend new money on latest technology just to go online. So they're using equipment that maybe the quality's not fantastic, but I've been actually teaching them how to set their lights up so it just looks that little bit better, and how to use the microphone so that they can enunciate their words more clearly. And actually, some of the feedback I had from a couple of the guys at Wolverhampton was, I've learned how to use the camera now. It's fantastic. And you've already alluded to the fact that people are already working online now in GP surgeries, which is probably going to continue once this is all over, I would have thought. Because
certainly far more than it has been,
Yeah, I mean, in some cases, it's a more efficient way to work, unless the patient is seriously ill, in which case, obviously, they have to come in or dial 999. If it's for just regular, what you would call, I guess, minor things like sore throats and that, and people are concerned about it, they don't need to go into the surgery. They can have a chat with the doctor, explain what's going on. And if that clinician has learned to use the technology effectively, they'll be able to interact beautifully with the patient. In fact, I personally find working with the students doing role play online is there's hardly any difference between doing it face to face.
Interesting.
And of course, it saves money for everybody, because it's cheaper to hire someone if they're online than it is for them to come in, because there's traveling expenses and things like this.
Yeah.
So I mean, at Meducate, we're trying to embrace that whole technology to also, train students how to use the technology. And it only takes 20 minutes to learn, a few
simple things, isn't it, sometimes?
Yeah. So, I mean, it's been a challenge for us as well, but obviously, I think you just have to embrace it. It's called change, isn't it? And it's
and that's something that we've been, really appreciative of. Regarding you guys, is that you were able to get on board very quickly and and react actively and appropriately and in timely fashion. And like I said, the students got so much out of that. Just those simple things sometimes as well. And
it often is. I mean, it's like you say, it's having that friendly voice at the other end. That's not an academic who has been doing it for 10 to 12 years, has done more OSCEs than anybody. I think students like that. They like that honesty. It's like, well, I was in it, and I can tell stories because, we learn through metaphors, don't we? We learn through stories, and human beings are essentially storytelling animals. And I can, and my colleagues, we can wax lyrical about the time a student did the following, and everybody laughs and they go, oh God, I did that. I did that when I was doing the training. Yeah, well, you won't again, will you? No, absolutely not. Some of my PR stories are hilarious, but students learn from storytelling. And
absolutely.
academics don't always have the time for that, because you've got to get a body of knowledge and information and methodologies out to the students so they become good clinicians and are safe. That's the other thing, safe at what they do. Our job is to ensure that the human being comes out, if you like. There's a, you know, when you're interacting, you're human. Let's just be human about this. I remember working with Mark, and I remember years and years ago, and he said, what you need, all that was lacking in that communication, young man, was humanity. Why, you know, and he said, why are you doing this job? And they said, to help people. So what would you do if I was your friend and I was telling you this problem? Oh, well, I might move towards you. I might be, okay. So just be human. It's another person in front of you. And I think sometimes when I've seen role play, simulated patients, that humanity's not being expressed, if you know what I mean.
Yeah.
And I think our job is also to remind the student why they're doing their job, because you care about people. You care about people. Imagine this is real. And that's the thing, isn't it? It's about being able to bring a sense of realism to the role.
Yeah.
And that applies for ACE, because I've done a history and a respiratory exam, and then I've been getting the student to talk to me while they've done the respiratory exam, and they've said, "Oh, that felt more natural." Yeah, absolutely. And guess what? You did it correctly, because you've been rehearsing it. You know unconsciously where to put that stethoscope. You know where it goes. Have a chat with me. And it also calms the student down as well.
Yeah, absolutely. I totally agree.
So, I mean, yeah, the whole COVID thing, big challenge. But it's been working.
Something that's worked, you know, and something that I think has worked well with yourself and others on developing that. And, you know, that again, that's for us something that we're looking at with regard to blended learning and developing curriculum around different ways of communication and skills training. So again, it's something that I think, if you want to put a positive spin on, has been developmental. So
yeah. I mean, it's been a continuous process for me as well, you know. And every time I work with a different clinician, I've learned something, you know, because you know, there's always this, students always have this problem with, well, one clinician said to do it this way, another clinician said to do it that way. And I always say, look, if you look at the methodology, the principles underlying those two methods, it's exactly the same thing. What you need to do is focus on the one that you feel comfortable with, that works for you, and you'll be fine. Yeah. And it's just getting, you know, yes, there is a correct way of doing something, but you all clinicians work out their own way of doing things. I think one of the strengths that the ACE has, and certainly the simulated patients, the experienced ones, we know how to pass an OSCE. You know, we know what the examiners are looking for, more or less. And I've seen it. It's been so. I've worked with lots of different examiners, and virtually all of them have been looking for the same thing from the student. That's safe practice, confidence. Even if you make mistakes, that's fine as well, as long as you don't make thousands of mistakes. And being honest as well about what you're doing. And if you're messing up, you stop and you start again, you know. Yeah. And giving feedback like that to a student who's about to do their nationals has been really powerful. They've said that to me. They said, when you explain to me that the examiners are often, because examiners often will say things like, wow, you know, that's incredible that they can retain this much information and do it in 8 minutes. I'm very impressed. And that girl was extremely safe. That girl was extremely confident. That guy knew what he was doing. I know he made a few mistakes, but I would trust him implicitly. You know, you hear that so many times. And it's nice to be part of that process, you know. Yeah, and it's developmental for me as well, because I'm always learning. I mean, I'm going to be working with the orthopedic hospital, and some of the way they're doing the physical orthopedic MSK exams is changing to suit the changing times, I guess. So we're going to be, you know, we're going to get further training from the Royal Orthopedic Hospital, and it's great to be part of that. I love it because I'm learning new stuff. You know, it's my development as well.
It's evolving, isn't it?
Yeah, yeah. But I mean, unless you've got anything else to add, James, I mean, it's been great chatting to you about this stuff, and it's good to, it helps me work things out as well.
No, thanks for having me, Bob. I mean, as you
No.
know, it's something I feel incredibly strongly about, and I think it's such an incredible resource and an incredible approach to learning that is just so welcomed and so appreciated by our students. The amount it enriches their learning and development, not just actually as a clinician, but as a person as well. Often, I think it gives back that voice and that human factor. And as I say, thanks to you and everybody at Meducate. I mean, you guys are professional, you're approachable, you're something that I don't think our students could do without in a lot of ways, actually. So.
Yeah. Oh, thanks for that. I mean, I'd like to sort of, from years ago, I'd like to say, if it hadn't been for the University of Birmingham, and to be honest, and the ISU, I wouldn't be doing the job I'm doing now. So it's thanks to them that I am doing what I'm doing now, because I was given the opportunity to get involved in working with Professor Parl and Phil Begg and yourself and other clinicians, too many to even mention, who've allowed me to take this further, in terms of my development, So I'm always grateful to the University of Birmingham for having put me in that position in the first place, and I put a lot of time and work into it,
It's worthwhile. That's the main thing, isn't it?
Yeah. So, James, I'd just like to say thanks so much for coming on here, and I'll be working with you fairly soon at some point. That wasn't a threat.
I look forward to it, as you know.
I know. And take care of yourself, James.
Thanks, Bob. Thanks for having me.
Thanks a lot, mate.